We were called to an 81-year-old male complaining of shortness of breath. Patient stated he had emphysema, and it appeared that he was suffering from an exacerbation of this illness and in respiratory distress. Patient was tachycardic, tachypnea, and had low oxygen saturations at around 75% initially. The patient was obviously breathless and was struggling to speak to us. He could only take about 3 steps at a time before having to take a break. The patient was clearly time critical, so it was important that we ensured he was on the stretcher, in the ambulance, and en route to hospital efficiently. The patient was given 25 ml of salbutamol via nebulizer at 6 liters a minute, 500 micrograms of ipratropium bromide, and 200 milligrams of hydrocortisone via IV, which was administered by an ICP. The issue with this case was whether to treat the patient as an exacerbation of his COPD or as acute pulmonary edema. This issue was raised as the patient was on furosemide, which can be used to treat edema in patients with congestive heart failure, which the patient had a history of. Personally, when I saw the appearance of this man and after hearing his history of COPD, I immediately thought an exacerbation of emphysema, only because I was not aware of the clinical presentation of APO. After much debate, my mentors decided to treat the patient as an exacerbation of emphysema. I personally only knew how to deliver salbutamol, and I knew he was indicated as I auscultated and I heard a wheeze. However, I was not aware of IV or hydrocortisone and its effects on COPD patients. I have witnessed the effects of emphysema in my personal life and while on Prac, but never an emphysema patient in such respiratory distress. Prior to this case, I also did not have the skills to identify the potential clinical features of APO. The main issues faced for this particular case was the diagnosis, whether to treat the patient as an exacerbation of emphysema or as APO. This is because the clinical features and the way the illness presents is so similar. For example, according to the 2015 QAS Clinical Practice Manual, the clinical presentation of emphysema include respiratory distress, accessory muscle use, wheezes, crackles, tachycardia, tachypnea, pursed lip breathing, and the tripod position. The patient displayed all these clinical features except for the crackles. According to Cleland, Yassin, and Kajui 2010, they assert that the clinical features of APO include pale, sweaty, obvious breathlessness, sitting upright, cyanosis, reduced oxygen saturation, hypertension, and crackles. Again, the patient presented with all these clinical features except for the crackles and the cyanosis. Personally, I was not able to distinguish between the two, but the ICP was able to give us advice on the ideal treatment. The ICP stated that the breathing patterns are different in emphysema patients. This is supported by He, Zhang and Zhang 2014, which states that a person with COPD typically breathes at a rapid rate, with slow breath volume and usually with a relatively short expiration time. This is how the patient was presenting, which led my mentors down the path to treat him for his emphysema. In the future, if I was presented with a similar case, I would definitely take note of the patient's breathing pattern. I believe now I can distinguish the difference between emphysema breathing patterns and APO breathing patterns. For example, I would take notice whether the patient was using a pursed lip technique and if their expiratory time was relatively shorter. This would indicate the patient was suffering from emphysema. In the future, I would also assist and encourage the patient to sit himself on the stretcher faster as he was quite time critical. He was very concerned with his house and wife and making sure that he had everything he needed, which worsened his condition significantly. Therefore, I would definitely be more straightforward and helpful to ensure a faster transport time. All in all, this case and this experience has taught me a lot, especially about emphysema and APO, and I believe I will have the skills to manage this case better in the future. Thank you.